Okay, we're getting into the last thing of the day. So we talked about there's kind of three physical things that we can work on, not cognitive, right? There was the physiological problem, there was the visual ocular issue, and then the last one is cervicogenic dizziness. So we talked somewhat in our other talks about vertigo, right? In that there's a difference between how people perceive dizziness. There can be, the people who feel like they're getting knocked over. There's the people who are just feeling a little spacey. There's the people who have difficulty to get off the elevator, and they're, whoa. And there's the people who literally cannot stand up because they're falling over. But when we're doing an assessment or looking at things, we want to know, are they spinning? That's true vertigo as the medical definition. You can have dizziness, and you can have presyncope. So presyncope is that idea that you're going to pass out. And sometimes they have all of them. In a 2014 study, so Letty is one of the key people out of the University of Buffalo. They did a study. They looked at 128 people. There were high school kids and college athletes who had concussion, got pulled off the field because of concussion. Of the people who had problems, right, most of them, 2/3 basically, had either neck problems or vestibular problems, which includes vision problems. The remainder had that physiological change because they are thinking that we can get people on a treadmill, get them back to sports. They were hoping a lot more were in that physiological range. Okay, but what they're thinking is the people who are in category 1 need a lot more skilled intervention. The resting isn't the thing that's going to help them. The other thing that they found from their study, they were hoping to find, the patient tells me this, then I know it's this thing. Unfortunately, that was not the case. They have to actually be assessed. It'd be too easy, right? In 2003, there was a definition for cervicogenic dizziness. And basically, it just says it's symptoms of feeling out of balance that come from the neck. How do we know somebody has it? It's an exclusion diagnosis. It's not their ear. It's not their medication. It's not their physiological things. Everything else has been ruled out. Their neck hurts. And if we work on things on their neck, a lot of times it gets better. I found this great website. This is from the class I just took this last weekend, so the slides that I gave to Annette does not have this on here. Dr. Timothy Hain is I think he's an ENT out of Chicago, but he has this great website that has all the different kinds of vestibular dizziness causing things that is for being able to do patient education. Or if you don't know, you can look up yourself. So we talked about this ad nauseum probably today now, right? That things can come from blood pressure, low oxygen. So we need to clear all the medical issues. We want to look at vestibular function, both central and peripheral. So central means the brain, peripheral means the ear, in terms of what physical therapists and occupational therapists do. We want to look at, is it a processing issue? Usually that has to do with vision, but sometimes it's just how they relate to where they are in space. Do they have decreased sensation, or if they have neck issues, which is what we're going to be talking about. If you're going to have a person who has trauma, I think this, I don't remember exactly, but it's upper 90% of the people who have trauma also have neck injury. It's a huge number because it's almost impossible for people not to have both. So before you do a lot of head motion, we should be testing for the orthopedic precautions, also looking a transverse ligament and alar ligament specifically. I don't see a ton of those, but I've seen probably in the last 5 years 4 that have missing something that I don't want to be moving. What's surprising is people can have a lot of motion in there, and it's scary to me, and they do a motion x-ray and they say, well, we're not going to surgically stabilize it, so go ahead and do whatever you want. But it's like 5 millimeters of motion is what they have of their dens going towards their spinal cord, and that seems like a whole lot to me. So then we work on different things than having them wiggle around a lot. Looking at vertebral artery testing, now that is in there because that is the standard of care within the American Physical Therapy Association and most orthopedic things, even though the test is not considered a good test. But CYA, and you should do the test, so at least you can say, I did it. Because you definitely don't want to have the person having a stroke on your watch or a spinal cord injury. So other precautions are constant vertigo. Now, some of these precautions are there because not all, if a person already is diagnosed with a central processing or brain injury, so the constant dizziness, lateral propulsion, facial asymmetry are all neuroscience. So if they haven't been evaluated by a doctor or a PA or somebody for their neuroscience stuff, and they show up at your clinic because they're falling down or something like that, I would want them to be checked out by a doctor before I do a whole bunch of other stuff. And then you have the 5 Ds. Again, almost all of my patients have dizziness, double vision. A lot of them can't swallow well because they have neck issues. So those aren't absolute precautions, but if somebody has not been assessed for that, that would be something I would want them to see somebody before I work on them a whole lot. So typical patient complaints with cervicogenic dizziness sounds just like everything else we've looked at so far, right? So they're dizzy or not feeling balanced, they're tired, they're falling, they're having difficulty with reading, they're avoiding all motions, they don't like to go out in public because thinking and having people around is too hard, they're having headache and neck pain, they're having sympathetic things, so they're freezing and then they're sweating and they're having all those kinds of problems, and they're not sleeping. So it's hard to make this list and the list that has anything to do with concussion separate. Most of the time they have both. So one of the things I did is I put a list of, kind of what's the difference between, say, vestibular system issues and if it's from the neck. One of the big things is people who have neck problems will complain of nausea or vomiting. Feeling like they have pressure on their abdomen, feel like somebody punched them in the gut. Most of your people who have ear issues are kind of just spacey, or maybe the room is spinning or moving, but it's about movement. It's not about, I don't feel well. I don't feel like I can eat. Most of the people who have vestibular problems are not sensitive to light or noise. Their head feels heavy. A lot of times their symptoms are worse in the morning, whereas a vestibular person will have their symptoms with either visual challenging activities or the more they move around. So there is some differences between the two, which kind of helps us. So some clinical findings that we can do, that they can have problems with, is if the person has horizontal nystagmus, that's more likely to be a neck than a central problem, which will have vertical nystagmus. So anytime anybody has two images, one on top of each other, that has to be central, has to be the brain. So they'll have joint position error. So when we were out here and you have the one with the plus sign, and they do their testing and their head is turned here, and they say they're in the middle, that's a joint position error. They don't know where they are. They can have dizziness when they return to sit, but it's not hypotension. Okay? So it's not a low blood pressure issue. It has something to do with all of a sudden have gravity pushing on your head. Frequently, they will have normal balance. They're dizzy all the time, but you do a balance test and they're perfect. Frequently, they'll have trauma. And I apologize to the chiropractors in the group, but I frequently get people that have had a manipulation at a chiropractor and now they're dizzy because they're now either overstretched or something. It didn't go well as it was supposed to. But the biggest thing that we know that is a cervicogenic issue is if we work on the cervical spine and it gets better. Okay, if it gets better, then we know some of the issues coming from the neck. So common findings is decreased range of motion. Now, frequently the person will also have headaches with this because Dr. Murphy talked somewhat about the greater occipital nerve, which comes from the top of the neck up and over the top of the head. And it has different places where it can go through the muscle. So there's a muscle going from the head to the second vertebrae, and that nerve will go through there. And if that muscle is always working, it will give them headaches. Some of the things that we're finding now is that if we do a range of motion test with the person's head flexed all the way, usually they're laying down, and you turn their head and they have less than 20 degrees of rotation, that's usually a cervicogenic headache. So the research has not been done yet for if the person will have dizziness from that, but frequently you see both of those together. Frequently you'll see visual changes. It doesn't have to be nystagmus, but it can be. A lot of times you'll see what's called staccatic interruption, so their eyes going like, it should be sweeping back and forth, right? And they'll go, okay? Sometimes you'll see those with up and down, but it's more that the person already has trained themselves to do that because they wear bifocals or trifocals, right? So if I see it going this way, I'm not so worried about it because if you've been wearing those glasses, you learn to, I stop here because I want to read, right? So that's not necessarily a problem. Most people will have increased symptoms with reading. They also have pain to palpation on the right side of their cervical spine, and if you do palpation, C2 and C3 are rotated to the left. I've only had 2 people ever that are rotated to the right. If they're rotated to the right, they have headache, but they don't have dizziness. I don't know why. That's what you see. You'll have muscle spasms of the sternocleidomastoid and all the suboccipital muscles. Frequently, they're using upper trunk breathing strategies. So they're breathing through their shoulder blades, not through their diaphragm. They can have pain into their arms, and they can have thoracic outlet syndrome issues. So the person who comes in and says, I have stocking glove numbness. Sometimes I've even had people have things in their legs, and they're dizzy. Sometimes I need to look at their thoracic spine, but that will also lead to cervicogenic headache. And usually they're very emotionally distressed because this is really wrecking their life. So what is dizziness? So what we describe dizziness is the thing that when 2 parts of information from our body are telling us different things. So if this ear is telling me, or I'm only getting 75% information from this side and 100% from that side, I will have dizziness because it's not equal. If I have a situation where my feet, because I don't have sensation, are telling me one thing, and my ears are telling me something else, I can have dizziness. Our body likes to have everything match up, right? So if you're sitting in a boat and you're looking at stuff, the wall's not moving, you're not moving, but the boat is moving. That's where people can get dizzy, right? He said, because it's not a match, okay? So if your neck is constantly turned this way inside, but your body's telling you it's straight, you're always going to feel somewhat dizzy because there's a mismatch. And especially if it's making your eyes do this. So they should always match. So our cervical spine is supposed to be the platform that lets everything else do its job. So part of what we need to be able to know about where we are in space is not only see what's going on, but we also should have a sense of, is the noise coming from over here or is it coming from over here? If our head is tipped, but we don't know it's tipped, that distorts where we think the sound is coming from, and it can make it difficult for us to know where we are in space. So there's another structure that we have in our neck that is really, really important because it has to do with the function of a lot of cranial nerves. So our trigeminal cervical reflex, there's a thing called trigeminal pain syndrome, which can be people that have headaches kind of on the side of their face because their trigeminal nerve is irritated. But it affects more than just that part. And because that thing goes all the way to C4 within our spine, if our neck is messed up, we can have problems with our cranial nerves. Okay? So that can be things like, if for example, your phrenic nerve, if it's having problems, that might be why we're having problems with regulating heart rate, right? Because that's part of its job. There's ones that have to do with swallow. So that sometimes I'll have patients who can't, I'll ask them, do you choke on food? And they'll say yes. And as we get their neck better, they can swallow. But it's not, it's not necessarily the kind of issue that is, that they have to have surgery for something. It's just how it's working. So the trigeminal nerve has all kinds of things that it works on, and one of the things that's really important is this whole idea that they not only have neck pain, but they will have problems with, proprioception, knowing where their eyes are, all those parasympathetic things that we were talking about before, sinus pain, face sensation pain. I have many patients who complain of numbness and tingling of their face. But they will also have inside their mouth muscle spasms as well as TMJ from this problem. So it becomes a lot bigger issue. So this is just a picture of where the trigeminal nerve goes. Part of that goes down into the spinal cord. So if you have whiplash, the top couple vertebrae are messed up. You can be pinching or tractioning or changing how that nucleus is working. The other thing is that we'll find a lot of people with our concussion folks that will have issues with their kind of all the nerves, the cranial nerves that are around the pons. But they also, as you can see in the picture, you get down into, there's still things coming down into the spinal cord that are cranial nerves. There's also a thing called dura mater, and for people who do like cranial sacral therapy, one of the things I see frequently here is people fall on the ice, and when they fall on the ice, they pull their tailbone, which then pulls on their dura, which then can cause a lot of these symptoms. So we have to at least rule that out, but think about it. But it also attaches to all these nerves. So this is kind of talking about the dura influence versus the what's coming from the vestibular system. And so what's important about this is that they have a lot of overlap between the dura and the vestibular systems. In case you haven't done your anatomy in a while. So one of the most important structures, I'm going to come pointing out over here. So this muscle right here is your greater rectus capitis posterior major. So I'll show you over here too so you can see. So it's this one right here. That muscle has the greater occipital muscle or nerve goes right through the middle of it. Okay, so if it is always turning on because you have whiplash, you know how people get really stiff and sore in their neck and they can't move it, that nerve will get irritated and cause a lot of the headache. But it will also make it so that it locks up that whole part of the spine. And then this is a picture of all the muscles of mastication. And those muscles can also be affected. We talked about which ones get affected by that upper cervical issue. Kind of what's interesting, because of a lot of our patients are having issues with that whole sympathetic nervous system. One of the things that I'm really trying to look into, because I did some craniosacral training this year, and what I'm having some good results with is trying to open up the jugular foramen by moving C1 away from it. And if you look at this picture, it shows you how out of the jugular foramen, the vagus nerves comes out of there, the accessory nerves, which is the ones that turn on all these muscles, and it also has this the hypoglossal, which is part of swallowing. So I will have patients who have all those symptoms move C1 and they all go away. So that's one of those things that is kind of interesting to think about, how maybe some of what it's happening at a cranial nerve level, but maybe it's not so much central areas. So there's also something that we have to consider is the mechanical receptors. So within our neck, or every joint of our body, we have a lot of information that comes to each joint that tells us where we are, how fast we're moving, what's going on. The head or in the upper cervical have the most of those in terms of proprioception of the entire body. So if they're not able to tell you information, it can make you feel very dizzy. So things to consider when we're doing our evaluation and looking at a working theory, right? So first of all, patients can have more than one cause of dizziness. And I would say most everybody that I see has more than one, right? So, where is it coming from? What's the most important thing? If they're having headaches and they can't sleep and they're in pain all the time, I got to treat this first, right? If it's coming from their neck, and a lot of times that will get them undizzy, then you've just made your person very, very happy. But you want to be able to figure out where is it coming from. Vertigo affects all aspects of a person's life. People who have severe vertigo are not doing much. They're not going to work, they're not taking care of their kids, they're not doing activities because they don't feel very good. Patients tend to do better with with physical rehab if it's a systematic approach. If you try the neck and do something of this, maybe a little vestibular something and a little bit of something here, pretty soon you don't know what worked and what didn't work. So then they come back next time, they say, I'm way worse. And you don't know. Did the neck make them worse? Did the exercise and walking around the block make them worse? I don't know. So doing a systematic approach seems to help. Patient education, as I said before, is really key. If you're not familiar with VITA, which is the Vestibular Association website that's up there. One of the things that people really like from that website is there's like a patient blog. And what they like is they have people who are having difficulty going to the grocery store, just like them, or can't go to church because they can't stand the movement, and people will say, well, I tried this and it worked, or that kind of thing. So they have other patients telling them this is what worked, and so that seems to really help. They also have a really great article on vestibular migraines. Now, some patients I put in cervical collars, and I tell them, when you go to your doctor, they're going to tell you to get out of this. Because the thinking is, if I put them in the collar, from the doctor's point of view, they're going to get weak, right? Because they're not going to use their muscles. I put them in the collar because when their cheek touches something, they know where they are. If they have a lot of muscles that are turning on all the time, it allows them to rest because something's helping take some of the weight of their head off. If they go in the car and it's bouncing them around and they can't stand it, the collar sometimes helps so they can get to their medical appointments. Okay? Do I want them in it for the next 10 years? Absolutely not. But if I can get that person so they're no longer just laying in bed doing nothing by putting them in a collar so that they can walk, then I've done them a favor. But they'll go to their doctor and the doctor will say, take it off. And then they take it off and then they can't do anything. So I want them to get stronger. So our treatment challenge is trying to make sure that their neck is giving them the same kind of information that they need to know, that it's accurate. So that when they say this is middle, it's middle. It's not over here, okay? So that's what we as therapists have to work on. Now, one of the things from the conference that I went last week, and I haven't got a chance to read the actual study, but they had done a study in, in hockey that was published in 2013. But like I said, I haven't got a chance to read it myself. But what they found in the study was that if people, for every pound of increased neck strength they had prior to the hockey season, their chances of having concussion decreased. Okay? So the VA of Tampa is using that information and trying to study does symptoms from concussion go away with increased strength. Does that make sense? So that will be something that's coming up on the horizon. But if you have somebody that you know that might be at concussion risk, that seems to be one of the best ways to protect them from being able to have concussion. And if you look at demographics and that kind of thing, who has more concussions? Young girls. They have weak necks.
How do you strengthen it? Yeah, I was just going to say, what kind of
So,
exercises?
So, of course, all the PGs are like, of course you know how to do that, right? Well, I mean, somebody said yoga. There's lots of things that you can work on for neck strengthening. But you don't want to start with heavy weights or resisted training if you don't know what's going on, and so there's not a blanket, But even doing a sit-up works on neck flexors, or working on cervical retraction, especially helps with deep neck cervical. But holding it here.
My son's team, they do circuit training like every Tuesday. Is there something they can incorporate for one of their circuits that?
Right.
Goes for those muscles.
So I mean, it's hard to give you specifics just because I don't know the population and all that kind of stuff. But definitely, anything that's working, having them work against repetitions in any direction, working on maybe a little resistance. It just depends on how weak are they.
I just shared that at the Anchorage Senior Activity Center, we have seniors that that are 5% on the top of the nation. And they started at 2 ounce weights. In the last 5 years that I've been there, they're up to 15 to 20 pounds. And it's all about the instructor and your teacher and educator. He educates them and he brings them up to certain levels. So
it can be. I mean, there's not a blanket way to make it stronger, but just depending on what's going on with their neck. I'm reluctant to say just do this and it'll be better, because you could cause a whole bunch of neck injuries if it's not done correctly. But I thought that was a very interesting study, just to look at, how can we prevent this, because pretty much they all have the same kind of gear, but severity of injury was related to strength.
Do you have the name of that article?
I don't, because like I said, I just learned it last Saturday or Sunday. But I would guess that it was through hockey. And it was in 2013. And neck strength and concussion, if you probably Google that or PubMed it, you probably can find it. Any other questions, concerns, things that people want to know? So that's what I had to present, which you guys are not so sad that you get out of here maybe early.